And it's always important to know how patient populations are selected for a study. So this was done at in a university setting. The controls were women who showed up to a health clinic with sore throats or whatever else, and they did a depression assessment on them. That was the control group. The intervention group, the women that had abortions, an ad was run in the paper that said, if you've had an abortion, we'd like you to come and be evaluated with psychological testing, and in return for coming and participating in our study, you'll be offered free counseling. So this was to me, picking a population in sort of an odd way to get a highly predictable result. And there are huge examples that are like that. Also, what happens with the population? I'll give you an example of, I don't know if you obsess about intention to treat when you read a study, but here's an example. Here's comparing medical therapy to surgical therapy for carotid endarterectomies. Now, when you look at the data, certain people are excluded from getting carotid endarterectomy because they're too sick. They're too much of a surgical risk, so they get kicked out of that arm. But if they don't also get kicked out of the other arm, then you've already prearranged so that this group is going to be much worse. The lead article in the New England Journal years ago, the first major publication ever on carotid endarterectomy, said the following, is that patients, and the abstract basically was, you did better if you got carotid endarterectomy. But explicitly what the statement was patients who survived carotid endarterectomy without a stroke had a much better outcome than people who were medically managed. And that entered the era of carotid endarterectomy. The stuff about sensitivity and specificity and negative predictive value. Here's one of my favorite studies. This is a study on how good, incidentally, how many of you use Bayes' theorem at work? Raise your hand if you do. Okay, we have one, we have two. Let me ask you a question. I got a guy that falls off a ladder. He lands on his calcaneus. He's got severe pain, so you're very suspicious of a fracture. But the plain films are negative. So how many of you would discharge the patient? As I described the case, how many of you would now discharge the patient as opposed to going on and getting a CAT scan? So how many of you would get a CAT scan? So you just used Bayes' theorem, is that you had a pretest probability. You didn't give it a number, but in your mind you said, you know what, I'm really worried about a calcaneal fracture. You did a test. You knew that test wasn't good enough to take them off the radar screen. So congratulations, all of you use Bayes' theorem, you just don't want to admit it in front of other people. That's all. But here's a study for you, and tell me what you think. 200 children that presented to our institution with trauma got a belly CT. And if the belly CT was negative, you were 99% sure that the child didn't have anything. Therefore, you would conclude that CTs are useful or CTs are not useful for the evaluation of belly trauma in kids. 99% negative predictive value. So good. So first question is, well, how many people actually had the injury? Because a lot of studies are published on people without the disease that draw conclusions about people with the disease. So this is actually an article in Journal of Trauma about 10 years ago. Of the 200 kids, 2 of them had an injury. 1 of them was missed on CAT scan. So in this study, actually, the sensitivity was 50%, but the negative predictive value was 99%. The negative predictive value of not going in the room and just saying, kids fine, send them home, is 98% in this study because nobody had anything. But when you start to read studies that give you things like negative predictive value, you have to ask, are there enough people in this study with the disease that this is useful? There's a huge issue with things like rules for cervical spine injury. Using x-rays. You already you're 98% certain they don't have anything even before you walk in the room. Because of all these studies, the same number comes up again and again. Of the patients we worry about 2% of them actually have something. So anyway, I'm glad that everybody uses Bayes' theorem and all that sort of stuff. A little bit on straw man comparisons. The emergency medicine abstract, I think, must have 10 or 15 articles that concludes the following, is that a therapeutic dose of ibuprofen is better than a subtherapeutic dose of acetaminophen. And these studies have repeated themselves a number of times, that, and ketorolac is better than a subtherapeutic dose of Demerol. So we have all sorts of cute things like that. And there are also straw man outcomes. The initial VMAX study on Niseratide that said this is the drug to use, and what did they show? What was their end? Anybody remember the end point? Is whether you felt better a few hours later. That was the end point. That was so. There are a few other things that were in the paper. They said, first off, that there was more side effects and more adverse reactions with nitroglycerin than there was with Niseratide. And numerically there was. But the type of reactions you got with nitroglycerin was you bottomed out your blood pressure for about a minute, or else you got a headache. The problem with Niseratide is much less frequently you bottomed out your blood pressure, but when you did, you bottomed it out for the next hour. The other thing that they found in the study, again, which of these are important patient outcomes as opposed to disease outcomes. They reported in the paper that patients that got, this is hilarious to me, patients that got Niseratide had a 6% lower chance of having to return for admission. Now, the big hoopla that the Niseratide manufacturer got into is that it was part of the FDA information, but was not part of the article, that they had it wasn't statistically significant, but they had a 6% higher death rate in the Niseratide group than the other group. So let's think of this for a minute. If you got Niseratide, you had 6% fewer readmits for congestive failure. You had a 6% higher death rate. I wonder if those two might be linked together by any possibility. But you have to laugh at this stuff. Other things that we need to take into account that pay attention to, for instance, treatment of influenza with, what's the stuff that costs $70? Tamiflu. How many of you prescribe Tamiflu for people with influenza? Not this year because you have resistance. But last year, how many were given it? And how much effect does it have? Yeah, it's about between a half a day and a day shorter symptoms. So I would sort of ask the patient, is it worth $70 to you to get better a half a day quicker? There was in one of I think it was reported in AMA News or ACEP News, I don't remember which. There was a study out of UCLA. I love this. I never have seen the publication, so if you've seen it, please let me know. But this was a study, it was done at UCSF. Is patients with the flu, with documented influenza, were randomized to the following treatment. You guys over here, all you do is just symptomatic treatment. Fluids, take Tylenol, Motrin, whatever else, but you get symptomatic treatment. We're going to treat you special. You are not allowed to take antipyretics at all. You have a temperature 104, live with it. You can't take anything. This group here, their duration of illness was 3 days shorter than the group taking antipyretics. Largest difference ever reported in a treatment arm for influenza. And, but it's not been repeated, I guess because there's no one, I guess if we had an expensive version of placebin that we could do, then that would work fine. Last point I want to make about is about spin. And there's the spin that you expect to hear about how pharmaceutical companies try to put spin, the best view on their products. But there's a much more common and subtle and insidious spin that you should pay attention to. that's just the use of adjectives. And the adjectives are rarely or very infrequently. So that when you read an article, you walk away with a sense that you don't have to worry about it. So here's an example of this. And it's not a pharmaceutical thing. It's a simple clinical problem. And it's a clinical problem that probably has a good clinical answer. But what do we do with infants that fall off a changing table, that hit their head? Do they have problems or not? If you read the literature on this carefully, this is what it will say. We had 40 infants. Only one of them had a skull fracture. Therefore, this is something that rarely do you have to worry about. And that may be true, but if you sit here, if I tell you that you have no better way of picking out who's got the skull fracture and that the instance is 1 in 40, then would you pass? Would you say, okay, I don't need to worry about that? Is that an acceptable miss rate? But if you read the abstract, that adjective sort of implants this sense in you that, oh, this is not something I need to worry about. So you have to, I always try to be very alert to how much of a difference does it need to make for me to actually treat. A good example is with the sinusitis. Is it really worth it to me to treat 15 patients to make one better? Or should I just say, if you get worse, return and the 1 in 15 comes back? Incidentally, getting back to the 1 in 40, one of the problems is, well, that's based on history. You know, how good is that? So we'll do one even better. We'll drop infants in the hospital in a controlled environment. So there's studies. There's one study of 160 infants, another of 80 infants, where we took them and we actually dropped them off the changing table while they're in the hospital. So now we're presumably not intentionally throwing babies on the floor. So we'll collect that on that. And guess what? We find exactly the same thing, that about 1 in 40 end up having a skull fracture. Except the difference in the conclusion of that article is it's not recommending that you check the physician and nursing staff for child abuse. When they bring them in from home, that's always a part of the article. Well, you have to check for child abuse because that shouldn't happen. It's 6:56, and you guys have been great. Thank you very much.